Hello, and thanks for watching Old School versus New School, the physio podcast, where 30 years of experience meets newly qualified physio and where things have changed over time for the benefit of our patients. And today we're going to talk about something that does get mentioned quite a lot in clinic, and hopefully we can have a bit of a myth buster session around the subject of electrotherapy. So when I started back in the day, electrotherapy, in fact, that's probably my earliest memory of physiotherapy. Yeah, is electrotherapy. And it was used extensively. But over the years, it gets used less and less, almost to the point of not being used at all, really, especially in a clinic like ours. And so we thought we'd have a discussion around electrotherapy and, as I said, hopefully bust some of those myths around it.
So, John needs to fill me in because, as you can guess, I don't know much about this. What types and what treatments was electrotherapy used for, we'll say, back in the day?
Back in the day, there was probably 3 or maybe 4, but probably 4 really. And they were ultrasound, they were interferential, they were shortwave. I was going to say shockwave, it's shortwave, and then the TENS machine. And they were used for all manner of things, really. Almost a one size fits everything. So probably the most prominent that was used was the old ultrasound. And still people mention that today. Yeah. Oh, why don't you use ultrasound anymore? But so they were the main ones, absolutely.
And what conditions did they help? What were they used for?
Well, the theory was that they'd help musculoskeletal conditions, so your tendinopathies, your muscle injuries, your muscle tears, and conditions like that, really, anything of a musculoskeletal nature. That was you'd go to physio and you'd have ultrasound, or you'd have this shortwave. I think it was shortwave diathermy. It's like a big biscuit tin we'd hold over the knee. We did used to call it the biscuit tin.
And clearly, to use it, you felt that it had some benefit at the time?
I think, yeah, yes, you were doing it because in theory there was a benefit. But what kind of I realised a long time ago, is that I wasn't sure. I wasn't sure whether it was having an effect or not. But of course, then you start to get into the research, and you look at the research, you start to read the research, and a lot of the research said the same stuff, and there was lots of it, and believe me, I read a lot of it, and they all came out with the same conclusions. This might be a good adjunct to physiotherapy. However, more research needs to be done on it, which I know that gets, I understand the theory behind this, but there was a pair of authors who were very well renowned, and it was about ultrasound specifically. And this is how long ago it was. So I read one of their early papers around ultrasound, and it was really interesting to see how I think it was 1959, and it was when ultrasound was new and it might be a good thing and all the rest of it. And they said in 1959, actually, we need to do some more research. It was actually done in vitro on frogs, something, or it was something kind of. But they're going, look, we think this might be a good idea. However, we need to do some more research. So I thought, well, in 1950, whatever, when it's new, that's fair enough, isn't it? But I then saw one that they'd written in 1999, and it was the same conclusion. I'm thinking, we haven't moved forward in 40 odd years.
Yeah. Of which people have been using it on
people for a long time. And they were only anecdotal, I've got to be honest. Anecdotal things where that actually, if you left ultrasound on for too long, it could actually damage tissues. So yeah, so because you might use the ultrasound, say it's set for 3 minutes, but of that 3 minutes, depending, because it was effectively pulsed, the ultrasound effect might only be for a few seconds of that 3 minutes. It was, It was really...
Yeah, and knowing, which we do now, being prescriptive about that. I can't be guessing, can we?
No,
Because how
no.
do you replicate that
Absolutely.
next session or week or whatever?
Yeah, and so that was all with the setting. So there were ways of doing that, but it was all almost like, so it became a little bit like, I'm really not sure about this. I'm really not comfortable doing this. And as I said, the research just really wasn't moving on. But it was, you know, it was what it was. Yeah, it's what it was then, really.
Okay.
What about you? Did you do anything about electrotherapy in uni?
We didn't do ultrasound. We didn't do sort of the complementary therapies, but in some of the alternative modules, different to MSK, what we do to the muscles and the bones and the ligaments, in neurological conditions,
Okay.
can be really, really useful as almost an aid, same as a walking stick or a splint would be. Something called functional electrical stimulation. I've seen used really, really well and really powerfully to get people's mobility back. It's almost a sensor that triggers an electrical stimulation when it's stood on to help lift a part of the body, usually the foot, to allow you to walk that you couldn't because the neuron's damaged or whatever. So that's where probably my idea of it is, but it's not necessarily a treatment in that aspect. It's more so an aid to go with it. But apart from that, not really. Obviously, we've been shown and we have used electrical stimulation for very new, let's say, knees or ACLs, just to get the muscles firing without joint movement, which is quite important. But I couldn't tell you this is what we were taught, this was the benefits. I've seen it anecdotally and I've seen the people work, and I know there is research for it, but only really in those post-surgical early stage rehab, which I think you're talking about.
Yeah.
Widespread,
absolutely. I think the other thing I should have said about the research that came out around ultrasound and shortwave was it was more placebo than anything. Yeah. So there's an argument around placebo, isn't there?
We don't mind a placebo, but we don't want it to be a placebo to the therapist.
It's almost embarrassing as a profession, isn't it, that actually we have to have a
placebo.
In prison clothes.
Yeah.
So we can't be doing that, really.
No,
so
absolutely not.
do you find patients still ask you about
yeah, absolutely, with the
electrotherapy?
Ultrasound, and more so if they've had it before. So, when I had my quad 10 years ago, I had ultrasound, do you do it? And obviously I don't, so I'm honest with that and say I've never trained in it, and I'm not sure there's much research in it anymore. I'm sure there's people they can find that still do it and would use
and
it.
I suppose if we know that placebo is a thing, actually, if it works for you,
if it works for you, it works for you. But I wouldn't be saying I can't treat you. I'd be educating a different way around the situation. Absolutely. So yeah, it's about education really in that aspect, that people don't necessarily always know what they need. They might know what they've had and know what they want.
Absolutely. They know they want to get better, don't they? And they've come
Exactly.
across this in the past.
We'll show them the current research and what we do to get them there, not what they've had before. Because it could be a completely different injury.
Completely different things. Now there is the TENS machine, which I do, which is slightly different because that's more for pain relief, isn't it?
I recommend that quite regularly now. But again, education, it's not going to fix you.
It's not going to fix you.
It's a paracetamol while it's on. It's working. You take it off, your pain will come back. Absolutely. We are liars if we say that it's going to make anything better. The next 6 hours after are going to be pain free. But to get someone to sleep, if you can put it on a timer setting, or if a certain movement, I don't know, getting dressed is quite painful, put it on in that time.
People are able to do that in their own homes, aren't they? They can go and get a TENS machine from Boots and apply it, and it doesn't need to be it's almost like a waste of your time with the physio if we're putting a TENS machine on, actually, because that's something you can do under your own steam, really.
Again, that would be another use of a placebo. We say, come in, we'll do the TENS machine, your back feels great, leave, 2 hours later your back hurts again. It's one of those things that we need to be careful of, but I used them quite regularly and educate people on the benefits of them.
Yeah,
Then
I think there's definitely a place. So you think about that there is a place for TENS, isn't there?
Mm-hmm.
there's not for ultrasound or the biscuit tin. Sorry, shortwave. But,
I mean, I've never even been spoken to about in 4 years about the shortwave in university.
Funny, isn't it? I mean, prior to that, sometimes people will say to us, and it's not strictly speaking electrotherapy, but it's like the heat lamp. Have you ever?
There is some research at the moment about red lights and things like that. Not heat lamp.
I mean,
hot water bottle, but
it's like a modern hot water bottle, isn't it?
Yeah. There are some different infrared therapies coming out, and I think it's coming from veterinary care. Really different lights and wavelengths of that, but we don't have it, and I don't recommend it because I haven't done the research.
We don't know enough about it,
we're not
really.
going to give people animal medication, so I'm not going to just apply one to the other. But I'm sure if there's research going on, at some point we'll find out about it. But yeah, I think.
So in your your training in university as treatment modalities, what kind of came to the fore really? What was the?
I think that's an interesting question because it was quite hands-off approach, and we don't want people to be reliant on us, absolutely, but there is a certain level of hands-on. When you say you want to be a physio, you need to be hands-on and comfortable with being hands-on, but we spent a short amount of time on manual therapies, hands-on therapies, none at all on massage, of which John put me through courses and things to complement for that. Advice and education is the two words. If that's the two words that were spoken the most at uni, it would be advice and education, which absolutely play a massive role. But we need other things to help you get there. If I need you to be able to bend your knee to 90 degrees, how are we going to get you there?
Yeah, we need to give that a bit of encouragement. There's got to be a way of giving that a bit of encouragement, hasn't there? Really.
Which is interesting because it was sort of a split reality. It sounds dramatic, but I was going to university and being told, oh no, you just need to give them this advice, you need to just give them this education. Fine. And then coming back and being in clinic and learning from other therapists and John and seeing how great our patients were getting on and how our outcomes were really positive when they were doing that, as well as massage, mobilisations, whatever it was. And I was being told at uni that isn't how you pass your exams, that isn't how you become a great physio. So it's interesting, that sort of split reality that I was getting, but clearly we were doing something right in the clinic, and clearly something's going right at university to be producing therapists. So
I think we use the term balance, don't we, when we're talking, and it's that whole thing that one thing can't be all right and it can't be all wrong, and that's hopefully where we get the balance right, and it's using the tools at the right time.
Back to the clinic and you weren't really assessing, you were just giving a massage and no education. Well, that's not doing it. You're a massage. You're a massage clinic at that point. But the combination of everything I was learning at uni and back at the clinic was the best for me.
Yeah, and I suppose we then go to the underlying principles, don't you? I know we're talking about electrotherapy, however, but when you look at the underlying principles of what electrotherapy was meant to be doing, that's
helping you along the way to adhere to the exercises, adhere to the education. I suppose that's how we get people better quicker, isn't it? Absolutely.
Yeah.
Absolutely. So, sort of a summary question. Do you think there is still a place for electrotherapy?
I think, short answer, yes, in certain instances. I think it's become less and less. I'm not. I kind of think that there will. I think to dismiss it. What I'm trying to say is to dismiss it is to kind of have a closed mind, and I don't think that's a really good or healthy thing to do. I think that things will. I think things will evolve, And for example, and it's not strictly speaking electrotherapy, is it? Shockwave, but I use shockwave as a kind of an example, which is a machine. So in some eyes it might be considered electrotherapy. I suppose are we saying electrotherapy / machines? I don't know, but I do think there will be things which may come along like the shockwave, like the functional electricals, and there's various things that will come along from time to time. The tricky bit is actually if something new came out today, how soon would we implement it in the clinic?
I think it's got to be researched.
And that's the trouble. And so the research takes time to evolve through, really. And we see it time and time again. People will say to me about the feet stimulation thing that
like wobble board sort of.
Exactly. You sit and you have your feet but that kind of thing. But like the Ian Botham, I don't know the first thing about that. I've seen the adverts, and Ian Botham isn't even doing the adverts anymore. I think Claire Bolden is. Claire Bolden now. Now I don't know the research on that. Not that I've looked a great deal. However,
physio would be going out of practice.
Yeah,
if
it was going
solve everything.
Yeah, and well, but not only that. If we said come into the clinic and sit in Ian Botham's foot thing, and we haven't researched it, and there's not any research, how can we advise it that it's a good or bad thing for? So I'm not even saying it's a bad thing. I'm not saying one. I'm not saying it's the other. I'm saying we don't know yet because it hasn't been around long enough to have a big tranche of meaningful information.
I think that's also where uni was massive, and also I think it perhaps might have evolved since when you were training. Is university was very aware that the landscape changes, and we were drilled into us evidence-based practice. Evidence-based practice. So even if that evidence base does switch a 180, does change because we know it does. For example, acupuncture or electrotherapy, whatever it is, a new bit of research might come out that we then suddenly pull back on massage, for example, that you've got to be prepared to adapt to what the evidence says, because that's all we can practice on. We're not scientists in the sense of we're trialing it on our patients. That's not what we do. We act on the information that we have. So.
And again, I think that's what differentiates us from other clinicians in the field, should I say, that actually we do, that's our mindset, is to react onto the evidence that comes out.
Absolutely.
Whether it be manual therapies, whether it be electrical therapy, whether it be, the next thing, exercise therapy. So do you think you were discouraged from manual therapies in university?
I would say so.
Would you?
Discouraged is probably, we weren't encouraged. We weren't told not to do it, but we weren't shown them all and encouraged as the way forward. They sort of allowed us to explore it on placements, and allowed us to explore it as an apprentice, so in our home clinics. But I would say out of 4 years, we probably spent 3 days on manual therapy.
Did you?
The rest was really looking at evidence bases and where we stood on different things that come out. Obviously, we learned the diagnosis side, but the actual treatment side was less, whether that's because we were apprentices and they knew we were with physios all the time. We had more contact time than anything. Perhaps that was why they knew we were looked after in that way. But definitely, I would say more of a defensive practice, because what if someone said you hurt them, or what if, well, it's all about informed consent, it's all about explaining what you're going to do, stopping, checking, which I probably learned more at my home clinic or my base clinic than at university. It was like, this is how, go away and see how you use it. It wasn't really a practice thing.
Yeah, I remember going into, just thinking now that one of the hospitals that I did one of my placements, which is part of the learning blocks, and there must have been a room, goodness knows how big, with so many of these shortwave machines. that you'd wheel into the cubicles, put people on, set them going, and leave them under there.
Crazy, isn't it?
And to know that actually it probably didn't work. It's
It's like a placebo. You've had something, so you should feel
yeah, it
better.
should feel better. It's amazing, really. I mean, you just couldn't. You wouldn't want to do it, would you? It's
No,
like,
absolutely not.
So, do you think that we're going away from the treatments, the passive treatments generally?
I hope not, because obviously my physio career is short in comparison to yours. But if I was not had to sit on my hands, was not allowed to do anything, whether that be helping someone stretch or massage or some FES placement, TENS placement, whatever it is, I'm not sure how much I could do. Yes, advice and education, yes, a diagnosis, but getting that, it sounds bad, but patient buy-in, that belief that I can get you better.
We can help you.
I'm going to show you what you need to do, and I'm going to get you there. We're going to work together.
We're going to prove it.
Is part of that.
Absolutely.
I've got to give a bit. You've got to give a bit. We're working together here. So I think I would struggle, and in some of my placements that I did, they were more hands off, and it did mean a lot. I wouldn't say overcompensation, but a lot more discussion around how we do things. Whereas I can just show.
How did you find that went with the patients?
The patients were getting better. I couldn't tell you at what rate because I wasn't doing the same manual therapy next to it. They were definitely getting better, and we know that because we know people that go to the NHS and do get better. There is, but the people that almost we land with sometimes are the ones that haven't got on with that advice and education and need that a little bit more.
That approach,
that mixed approach of the manual therapies, which we know people can get reliant on. We don't want them to. We would like to see you leave the clinic at some point, as much as we like seeing you. We don't want you in here forever. But I would say, I think I would struggle if I had to sit on my hands and just talk. I'm not saying that's all advice and education is, but no manual therapies, no other modalities. I think I would struggle. And from a physio point of view, about my job is to help. I'm going to give all I can to help. If you don't like shockwave, that's fine. We'll get rid of
we'll
it.
Do something else.
And we'll do something else. But I've got to give you on a plate all the options. Your best option, and you tell me
if you're okay with that. If you're not okay with that, absolutely.
Way around it. So I don't think it should. I hope it doesn't. I hope it doesn't go
that way.
Us having this plethora of options, but I can see if I wasn't an apprentice and in front of a group of physios at clinic, I would have gone that way because I wouldn't have known.
You wouldn't know any different, yeah. It's a shame that we kind of lose, and it's also from your perspective, Soph, having the ability to kind of deduce for yourself. Actually, this is going to work. This probably isn't going to work for this patient, and having those different tools in your toolbox, isn't it? Really?
Yeah, and John has always said to me since day one, pretty much, you won't learn how to be a physio until you finish your degree. Because then you can choose. You've got the knowledge of the evidence base. You know how to pick a good bit of research versus a bad bit of research, and you can go, I'm not using electrical stimulation anymore. I don't agree with that. Whereas when everything's so fresh and new, and you're just learning, this is how you do this. This.
Yeah.
You
get all the information.
Have that choice then. So it is interesting how it evolves through.
So I think what we're saying is electrotherapy was a thing. It could potentially be a thing in the future. It's not anything we want to be using in the clinic for the reasons that we've said around the research, around the fact that it has been most effective when it's considered a placebo. And hope that answers a few of your questions around the subject. So appreciate you watching, and hope to see you next time. So I hope that helps.
Thank you for watching. This has been John Price and Sophie Cook from Midlands Physio. If you found this helpful, please share it with somebody who might need it. And if you want any further advice or information, please get in touch with Midlands Physio. And our telephone number is 01562 754 380, or our email address is info@midlandsphysio.co.uk. Thanks then.